I want to thank Gary Bloom for inviting me to talk, and I want to thank all of you for being here because I know that you are all ambassadors and provide a lot of education, information, and support for the people who can't be here. And so you are a community of people that are really helping a lot of individuals that don't have the opportunity to attend a meeting like this. So Gary asked me to address this topic for you about how a surgeon would approach a patient who either has persistent or recurrent disease. I'm going to have a very surgical perspective to this. There's other perspectives, but I can address some of the questions you might have about those things. This, is a little bit of a lecture format, but I would prefer that if you have a question about something that is being said in the talk, that you can interrupt me. I'd like to address your questions during the talk, and if you want to wait till the end, that's fine too. The other thing I'll say is that if I use medical terminology or an acronym or something like that and you don't understand what I've said, please stop me and ask me to speak in English. I've tried to take some of the acronyms and define them during the talk, but if I slip and I use a medical term, just stop me and say, what does that mean? So I'm going to take the surgeon's approach to this problem, and by virtue of an outline for this talk, I'm going to ask a series of questions. These are questions that go through my mind when I'm seeing a new patient who's previously been treated for thyroid cancer and now we're worried about either persistent or recurrent disease. So the first question I ask is, what was the patient's initial management? And then next, I'm going to ask, what is that patient's risk of having recurrent disease or dying from thyroid cancer? What is the patient's response to their initial therapy? What happened after surgery? If they were treated with radioactive iodine, are they getting TSH suppression therapy? And then, is there persistent or recurrent disease, or do they have no evidence of disease? Is the disease regional in the neck? Is it distant in the bones or in the lungs, or is it in both locations? And does surgery, since I'm a surgeon, I'm going to ask, does surgery have a role? One thing to say is sometimes surgery doesn't have a role in treating a patient. And, the old saying is that if you're a hammer, everything looks like a nail. So to a surgeon, everybody needs an operation, but sometimes the best advice I give to patients is you should not have surgery. Then another thing is, what are the goals that this patient has? What are my goals for treating that patient? I think you should define those when you're seeing a doctor. And then, are there alternatives to surgery that might be a viable option for a patient that you see? Now I'm going to go back to a classic study published by Dr. Mazzafari. I know he was very involved in this organization. I'm using his study because of that. But it also is a classic study in the thyroid cancer literature. And what it did was it found that if you treated patients with thyroid cancer and then followed them for a long period of time, you found out that there was about a 30% recurrence at about 25 or 30 years. That's a very common clinical scenario. If you look at the slide on your right, you figure out that most of the recurrences occur early, and most of them are in the neck. They're not distant. There are some that are distant, but most of them are early and in the neck. And then the figure that's on the bottom right of this slide looks at age across the horizontal axis, and then looks at recurrence, whether it's distant, and what's the chances of dying. So if you look at very early age, 5 to 10 years of age, what you find is that there's a very high recurrence rate. The mortality is very low. And then as you age and you become middle-aged, recurrence risk goes down, mortality starts to rise a little bit, but then when you get to over 65 years of age, you'll start to see that there's a higher recurrence risk, and there's also a higher risk of dying from thyroid cancer. Now, Maria Albuja Cruz is one of my junior partners. She did a study at the University of Colorado Hospital, and we were looking at how patients did if they had a total thyroidectomy or a total thyroidectomy with a central neck dissection that was done for prophylaxis. It wasn't a patient who had clinical lymph node disease. And one of the questions we were asking is how common is metastasis to the central neck nodes in these patients? And lo and behold, we found that 50% of the patients have metastatic disease in their lymph nodes. Now, most of the time, this is very microscopic metastatic disease in the lymph node. It's not a large tumor because that would be a therapeutic neck dissection, not a prophylactic neck dissection. So if you ever see PCND, that's a prophylactic central neck dissection. There's the acronym for you. Now let's start with what's the goal of initial treatment for thyroid cancer. You can outline this in the following. Well, the first is you want to remove the primary tumor, and that should include any invasion of the tumor outside of the thyroid into the tissue around the thyroid. You should also be doing a therapeutic neck dissection for people who have clinically significant lymph node disease. Excuse me. And one primary point here is that the completeness of the first operation is one of the most important determinants of a patient's outcome. Residual metastatic lymph node disease is the most common site for patients to have persistent or recurrent disease. Let me pause here for just a second and talk about this persistent versus recurrent, because it came up with a question in the last session. You know, most disease is persistent disease. We use the term recurrence, but it's not really a recurrence. For example, if one of the ultrasonographers does an ultrasound of the lateral neck and the lymph nodes all look normal, and then let's say 5 years later, you get another ultrasound and now the lymph node looks abnormal. That disease has been there for the past 5 years. It spread when the thyroid was still in the patient's neck. It was a subclinical metastasis. The ultrasound cannot detect individual cells in a lymph node. And then over the 5-year course of time, that grew and progressed, and now it's clinically evident. And, you know, just so you know, Judah Folkman, who's one of the incredible pioneers in angiogenesis, a cancer researcher, he actually has described 6 different clinical scenarios for how cancer recurs. And thyroid is one of the paradigms of a cancer that stays quiescent for a long, long period of time and then has late recurrences, like 25 years later. That cancer has been there the whole time. It's been quiet. And then it became clinically significant 25 years later. We use that term recurrence, but it really is persistent disease, okay? Next, I want to minimize the risk that the patient is going to have a disease recurrence by effectively treating them the first time. And again, adequate surgery, I think, is one of the most important determinants of that. And radioactive iodine treatment and TSH suppression and other treatments right now play an adjuvant role, which means they're in addition to surgery, but they're not substitutes for surgery. I think we need to accurately stage the cancer. That gives us information about what the patient's future risk is. That's a term we use, prognosis. You've probably heard that already. It guides disease management. It tells us a little bit about how aggressive we should be in follow-up monitoring of the patient. It also allows us to talk to one another about common patients. Like if I'm talking about a stage 1 patient with another doctor, they'll know what I'm talking about, and that's different than a stage 3, 4 type of patient. We want to permit the active long-term surveillance of the patient, and we're going to change our strategy based upon that initial staging. And then we want to minimize the treatment-related morbidity. We don't want to make the treatment worse than the disease, and we can do that. We can easily do that with surgery or cytotoxic drugs. Now, what are the key steps in that initial management? This topic came up in the previous session. One of the key topics is to get an accurate lymph node mapping done before the thyroidectomy is done. And one point I'll make that Kristen was commenting on is if a doctor asks for a thyroid ultrasound, in a lot of radiology departments, they look at the thyroid. They don't look at anything else. So we ask for a neck ultrasound, which includes the thyroid, not a thyroid ultrasound. Or if we ask for a thyroid ultrasound, we also say, could you please do lymph node mapping? So don't assume if you've had an ultrasound of the thyroid that they actually looked at the lymph nodes. And so one of the key things I look at when I'm looking at a report that's not from one of the people I work with every day is, do they have any mention of the lymph nodes? If they don't say that the lymph nodes look normal, then I don't think they looked at the lymph nodes, and I'm going to order a neck ultrasound, not a thyroid ultrasound. Now, let's go on and ask, I think I missed some things on the previous slide. Yes, so if you have abnormal lymph nodes, I'm going to usually order an ultrasound-guided FNA of those lymph nodes. Ultrasound is very good, but it's not perfect. They can tell you a lymph node looks abnormal. We can have very high suspicion it has cancer, but I'm really not going to want to do a lymph node dissection without proving that that's cancer. I have done a lymph node dissection before based on ultrasound, and the pathology came back as these are abnormal lymph nodes, but there's no cancer there. That was a long time ago. It was probably before I started this practice of routine ultrasound-guided FNA, but you don't really want to put a patient through an operation that they don't need, which has its risk, and you don't necessarily benefit the patient by doing that operation. And then we do CTs or MRIs. I personally prefer CT scan because I know how to look at them. I'm less comfortable with looking at MRIs. I always have to find a radiologist to look at an MRI with me. If the patient has very bulky and advanced disease, people tend to think of, well, a CT is better than an ultrasound. That's not true. These tests are complementary. They give you different information, and that information is put together to get a better picture. So don't think of one as being better than the other. Think of them as being different. They complement each other. They give us a more complete picture. Then what about the surgical steps in that initial treatment? Well, did the patient have a near total or a total thyroidectomy? I'm going to use those terms as if they're synonymous. Or did the patient have a lobectomy? Total thyroidectomies should be done for people who have high risk, and that would include the things that you see on the slide. It's a large tumor, or there is extrathyroidal extension, or there's clinically apparent metastasis to the lymph nodes, or they have metastasis to distant sites like bone and lung. I think you could do either a total thyroidectomy or a lobectomy for people without those risk factors. And then there's always a question about people who've had a lobectomy, should I have a completion thyroidectomy? And the answer to that is that if what you know after the lobectomy would have made you do a total thyroidectomy at the first operation, had you known that information, that's when you should go back and do a completion thyroidectomy. Now, there's lots of gray areas that I haven't really necessarily addressed on this slide, but these are what I think are the hard and fast rules. And then when you get a gray area, you got to look at the individual patient and the individual factors involved in that patient. I think I saw a hand go up. Yes?
How does that relate to a situation where it's a genetic component and numerous people in the same family have the same problem?
Yeah, again, that would factor into the decision making about that individual patient. That's one of their patient factors. And in those types of cases, the family member's course may help predict this patient's course. And I would tend to be a more aggressive surgeon in that situation, and in those patients probably be recommending more towards a total thyroidectomy than a lobectomy. And I think in one of the other talks I saw earlier today, if you look at the American College of Surgeons Commission on Cancer's database, people with papillary and follicular cancer in the United States, about 85% of them are treated with a total thyroidectomy, and only about 15% of them have a lobectomy. Now, that's just a practice pattern. I'm not telling you that that's the right or wrong thing to do. That's what American surgeons do with thyroid cancer right now. Oops, I'm going backwards, aren't I? And then if the patient has clinically evident node disease, a therapeutic compartment-oriented dissection should be done. I'm going to get into the compartments a little bit later, so I'll define what that means for you. And then we do prophylactic central neck dissections in people with more advanced thyroid tumors, the larger or the locally invasive tumors. The really small, locally contained tumors, we wouldn't do a prophylactic neck dissection, but we would do a therapeutic neck dissection if we find clinically evident disease. Yes?
So would the actual surgery be any different between a therapeutic compartment neck dissection and a prophylactic? You know, if you hadn't proved it with an FNA before surgery?
So if I operate on a patient and I find the lymph nodes are abnormal looking, and I'm suspicious that they're metastatic cancer lymph nodes, I'm going to do what I will refer to as a therapeutic neck dissection. Now, sometimes I'm wrong, and the nodes all come back as being negative. I'll give you a common scenario. Many of you, I'm sure, have Hashimoto's thyroiditis or some type of other autoimmune thyroid disease. The lymph nodes being part of your immune system often grossly, to my naked vision, look abnormal. And because of that, I'm going to remove those. And commonly, those come back as being negative for metastatic cancer. But that's part of the proper staging of that patient. I'm not going to leave those abnormal lymph nodes and not know that there's cancer in there. Does that adequately address your question? Whereas prophylactic means they look normal.
Is the therapeutic any more radical, more extreme?
Than a prophylactic one? No, they're the same procedure. If you were here in the session before, the neck dissection is done based on your anatomy. We're taking the nodes out in a anatomic area, boundary. There was a question in the back.
If a patient is having a central compartment neck, a thyroidectomy and neck, a therapeutic removal of the lymph nodes,
And you are also finding that there is a left lateral neck that has to be done. But they say there's nothing on the right. By virtue of what's up there, why wouldn't you want to do a prophylactic on the right? Because there's already been a spread, and perhaps in 5 years, when you're 5 years older, I might have more morbidities, comorbidities going on. Why wouldn't you just remove all of them prophylactically?
Yeah, so I'm going to tell you what the general rule is, and remember that human biology, there's always exceptions, right? In general, lymphatic drainage occurs on the same side of the body and doesn't cross midline. That's a general rule. It's not always true. Bilateral lateral lymph node metastasis is not that common. It occurs with enough frequency that it is a situation we deal with on a regular basis, but it's really not that common. Most of the time, you're going to have disease that's on one side, and you would not really need to do the opposite lateral neck. Now, there's certain things that might predict that. For example, people with a high number of central nodes that are bilateral will have more commonly lateral neck disease on both sides. But the answer to your question, again, I'm going to go back and rely on my ultrasound colleagues, is that ultrasound is very good. It's not perfect, but it is very good. And if the nodes all look normal, then I think you're really going to be putting a patient through an unnecessary operation. There is risk involved. The recovery from a bilateral neck dissection is much more difficult than it is from a unilateral neck dissection. And so those are all the issues that I think go into answering that question. You know, the other thing I would tell you is that in the study that my colleague Maria did, we found 50% of people had microscopic nodal disease, but I told you earlier that the recurrence risk is only 30% in patients over 30 years. So is that microscopic disease partially treated by iodine? Is the levothyroxine TSH suppression therapy keeping that disease in check? Does the patient die of another disease before it becomes clinically significant? I don't know the answer, but those are all possible explanations for that. And again, part of a strategy is not to make the treatment worse than the disease. Does that answer your question a little bit?
yes, thank you. When you said prophylactic, I thought, and remove them all. Okay.
Okay. All right, so what is the patient's risk was the next question. And the way that we're going to approach that is by the staging system. So everybody in this room has probably heard of what stage of cancer I am. but maybe you didn't hear it really well explained to you. Most staging of cancer is done by what's called the American Joint Committee on Cancer. It's in its 8th edition. You'll hear us call it the AJCC. It's based on the tumor, the lymph nodes, and then distant metastasis. So you'll get a T, an N, and an M. And then the T, N, and M are combined into the final stage. The staging allows us to plan the treatment. It gives the patient and the doctor prognostic information. It allows us to evaluate the results of the treatment, and it also allows us to collate the information from different institutions so we can compare one institution to another. We can do trials on treatment, and we can do that according to the patient's risk. Now, this is the only cancer, well-differentiated thyroid cancer, papillary and follicular, is the only cancer that has age in the staging system. If you're less than 45, I told you earlier that the recurrence risk is high, the mortality risk is low. If you're less than 45 years of age, you basically have to have distant metastatic disease to be stage 2. Every other patient is stage 1. That's very different if you're over 45, where the recurrence rate is high and the mortality risk has gone up. Yes?
When you talk about age, at what point do this whole journey, are you judging an age? When you lump this down, or when you had surgery, or the first?
Yeah, it's at the date of diagnosis.
So what if you had, that lump has been there for 4 or 5 years before they actually diagnosed you?
Yeah, I would actually say it started when it was first identified by you or your doctor. Now, we use this, what's called a dichotomous variable. It's less than or greater than 45, but it'd be silly to think that a 44-year-old and a 46-year-old are going to do a lot different. But for the purposes of research and classification, age 45 is the one that's used. But it's really not that simple, because age, of course, is a continuous variable. We start at, 1 and we go to hopefully 88 or something. It's a continuous variable. It's not really a dichotomous one. Yes?
What do you consider a lymph
That's right. In thyroid cancer, generally we're talking about lung and bone disease. It can go elsewhere, but those are the most common distant metastasis sites.
Dr. McIntyre, you said that the staging is done at the diagnosis state, not at the surgical state?
Well, staging is a kind of a little bit of a continuous process, but when we talk about AJCC staging, we're talking about at the time of the diagnosis and treatment. So you do a clinical exam on a patient, that's part of staging. We operate, the pathologist gives us a report, that's staging. We do CT scans or ultrasounds or iodine scans or PET scans, that's all part of staging. But I'm going to talk a little bit about how we might see this as a moving target. But when most cancer doctors are talking about a stage, they're talking about the stage at the original diagnosis, not a few years later. So a common thing I see is I was treated with a thyroidectomy 5 years ago and I was stage 2 and now I have a recurrence, so does that mean I'm stage 4? No, you're stage 2, you're kind of the same stage for the rest of your life. But in thyroid cancer, we actually do treat it as a moving target, and I'll explain what I mean by that. I'm never going to get through this. But over 45 years of age, you'll see that when you go from N1A, which is central neck, you're going to get up into stage 3. T4A means that the cancer itself is growing into the tissue around the thyroid. That's going to make you a stage 4 disease. Now, I told you that part of the reason to stage patients is to give them information about what their future risk of recurrence. And you'll see that in this particular staging system, stage 1 and 2 has a pretty close local recurrence rate. That's not very useful. For that reason, the AJCC staging system has been heavily criticized by people that work in thyroid cancer. Now, what are the best tests to diagnose either persistent or recurrent disease? I borrowed this slide from my colleague Brian Haugen. We're going to look at a diagnostic whole body scan with iodine, recombinant human TSH stimulated thyroglobulin levels, the tumor marker that you're all familiar with, neck ultrasound, and then the combination of a thyroglobulin and a neck ultrasound. And here's 5 different studies And I'm going to show you the results of those 5 studies. Now, a diagnostic whole body scan is not very good. Sensitivity is the ability of a test to detect disease when disease is present. And you see that in the best case scenario, about 80% of the time the diagnostic whole body scan found disease, but in the worst case scenario, it was only about 25%. We used to do these scans routinely at various time intervals. We really have stopped doing that lately because of this kind of data. Now, the recombinant human TSH-stimulated thyroglobulin level is much more sensitive. You can see that ranges anywhere from about 70 up into the 90 percentile. A neck ultrasound is also pretty good, about 75 to 90% sensitivity. But if you do the combination of the two, you see that we're able to detect disease in close to 100% of people. Not 100%, but close to 100%. So really, our routine is to be measuring thyroglobulins, doing follow-up ultrasounds, and then all the other tests we do are dependent upon what that individual patient and their risk factors and the findings of those 2 studies are. So think of it this way. A serum thyroglobulin level is a tumor marker. It basically is asking the question, is this patient's cancer still around? Do they have persistent or recurrent disease? The neck ultrasound and any other kind of anatomic imaging like a CT scan or an MRI, it's asking, where is that cancer? And then we have these functional tests, the iodine test. The question that's asking is this cancer taking up iodine? What is the function of this cancer? We use other imaging tests like PET scans, and that's asking the question, what is this cancer doing? And that gives you information that might allow you to then manage the patient. Now, if you were here in the last talk, I'm repetitious, I'm just going to summarize, but what the neck ultrasound is doing is not only looking at size of lymph nodes, it's looking at the various sonographic characteristics of those lymph nodes. And there's various features that the ultrasonographer is looking for, and I borrowed these images from this publication in the Journal of Clinical Endocrinology and Metabolism, and so these are normal-shaped lymph nodes with an echogenic hilum. They look very benign. Here's a rounded cystic lymph node. That's going to be very suspicious. Here's one with increased peripheral vascularity. Again, it's very suspicious. And then here's a lymph node that contains what we call echogenic foci or microcalcifications. Those are terms you might see on your report. Again, that's a suspicious lymph node. So now let's talk about a particular study that looked at staging. And I'm going to use Mike Tuttle, who I think is speaking tomorrow or Sunday, so you can go talk to him tomorrow or Sunday, about the experience at Memorial Sloan Kettering in New York. They took 588 patients. All of these patients were treated by a total thyroidectomy and radioactive iodine. That's what those acronyms mean. The median follow-up was 7 years with a range of 1 to 15. And what the purpose of this study was to compare the AJCC TNM staging system to the American Thyroid Association risk categories. So here's those 588 patients according to the AJCC stage 1, 2, 3, and 4. And he looked at death from thyroid cancer, persistent or recurrent disease, and then no clinical evidence of disease. That patient appears to be disease-free. And here again is an example of the problem with the TNM staging system. If you look at 1 compared to 3, and you look at persistent and recurrent disease, it was 34 and 37%. Again, you're not seeing a separation in the groups of patients. And then if you look at those patients that are free of disease, it was 66 and 62%. Again, that staging system isn't really helping us. And this is one of the reasons why the American Thyroid Association came up with these different risk categorizations. So what I've shown you here is the criteria for a low-risk thyroid cancer according to the ATA. No local or distant metastasis, all of the tumor has been resected, there was no local invasion, the tumor does not have an aggressive subtype, an aggressive histology, no vascular invasion, and if the patient has received I-131, There's no metastatic foci outside of the thyroid bed. Now, many of you know that there's a 2014 revision going on, and in the low-risk category, the ATA has added these things. Things like, if you have metastatic disease in lymph nodes, is it microscopic and is it a low number of lymph nodes? There's some information about the BRAF mutation in that in here. Did you have a question, Denise?
So would you consider tissues like trachea?
Local invasion? Yes. Now, there's a difference between, a little microscopic local invasion and gross local invasion. Those patients do differently. So those are not synonymous with one another, okay? Now, what about the intermediate risk group? There is some invasion of the tumor into the soft tissues, or there is radioactive iodine outside of the neck on the first post-treatment scan. There's an aggressive subtype, or there's some vascular invasion. And here's the 2014 modifications. So as most of you know, this hasn't been put out yet because it hasn't been gone through the final approval process at the ATA. And then high-risk patients are macroscopic invasion of tumor. Remember, I just told you that microscopic and macroscopic are different. Then there's an incomplete tumor resection. Maybe it wasn't possible. And then there's distant metastatic disease. And so you can find this figure on the ATA's website where it looks at all of the various factors, and it starts at very low risk of recurrence and goes up to a very high risk of recurrence. And you can sort of give patients and their primary doctors or anyone else information about that patient's risk in the future. So now let's go back to Mike Tuttle's experience and look at the patients who had ATA low-risk disease. Overall, those patients had a 14% risk of recurrence, and of those recurrences, 85% of them were a positive tumor marker without evidence of structural disease. So only 15% of those patients had evidence of structural disease on an ultrasound or a CT scan. In the intermediate group, 44% of those patients had recurrence, and 55% of the time it was a positive tumor marker without structural disease. And then in the high-risk group, 86% of those patients had recurrence. Only 22% of the time was it biochemical, the tumor marker, but the majority of those patients you could find cancer on the anatomic imaging. Now, the other part of his study, which is getting to now, is the patient's risk a moving target? Do we restage a patient? And the answer to that question from his studies is that it's yes. What was the patient's response to their initial therapy of surgery, radioactive iodine, TSH suppression therapy? They defined an excellent risk or an excellent response as someone who now has a suppressed or a TSH-stimulated thyroglobulin level that's less than 1, and the neck ultrasound is negative, and if there's any other imaging, including an iodine scan, that's negative also. An acceptable response is that the thyroglobulin level when it's suppressed is less than 1, but when the patient is stimulated, either by withdrawing their thyroid hormone or giving recombinant human TSH, the thyroglobulin goes up into the intermediate zone of 1 to 10. If there's a neck ultrasound done, there might be some nonspecific findings that we really can't define very well. And if there's another imaging or a scan, those findings might be nonspecific also. An incomplete response is someone who, while they're taking their levothyroxine, their TG level is over 1, and when you stimulate it, it goes higher than 10. They have a rising thyroglobulin when it's being monitored and rechecked over time. And they have disease on their imaging, either ultrasound, CT, or scans. That would be an incomplete response. So now we go back and we look at the patients grouped according to their response. And if the patient had an excellent response, at the end of their follow-up, 96% of those patients were disease-free, and only 4% of those patients had persistent structural disease, or recurrence, I mean. In the acceptable group, 87% had no clinical evidence of disease, 13% of them had a positive tumor marker, but none of the patients had structural disease on the imaging. And then if the response was incomplete, only 4% of the patients were disease-free, 39% of the patients had a positive tumor marker, 57% of those patients had structural disease by imaging. None of the patients had died during the period of this study, which was, I told you, a median follow-up of 7 years. Now let's look at the patient's initial ATA risk category, and then let's re-estimate their risk based upon their response to treatment. So in the low group, the ATA risk was 3%. If you look at the people who had an excellent response, it was 2%. And if you looked at the people who had an incomplete response, it was actually 13%, when the ATA category had said that they only had a 3% risk of recurrence. In the intermediate group, the ATA would say an 18% risk of recurrence. If the patient's response was excellent, it was as low as 2%. And if it was incomplete, it was 41%. And then if the patient had high risk, the ATA would say 66% chance of recurrence. But yet, if the response was excellent, it was as low as 14%. And if the response was incomplete, it was 79%. This problem with the acceptable group is a numbers problem. This is a big study, 588 patients, but it's not big enough. In that one category of acceptable response, 95 patients is not enough to tell you how these patients are going to have disease recurrence. So don't misinterpret this as if you have an acceptable response, it doesn't matter what ATA group you're in, you're never going to have a recurrence. That's a numbers problem. You had a question? Yeah, this is all adults, it's not children. Okay, so I'm going to use a patient as an example to illustrate some of these points, and it's not a patient that's in the audience because I know who this patient is and it's not, that person's not here. So if you think I'm talking about you, I'm not. 51-year-old female had a total thyroidectomy done, not by me, but at another institution, just to illustrate the points. 2.5 centimeters of papillary thyroid cancer. There were no abnormal lymph nodes seen. She was treated with 100 millicuries of I-131. The scan showed uptake in the thyroid bed region. That looks like a pretty good response. Because she's 51, that's a stage 2, a T2N0M0. 6 months later, she had follow-up with her doctor. Neck ultrasound was done, which was negative. She's given Thyrogen and done a whole body scan with 4 millicuries. That was negative, but the TG level goes up to 28. Again, this is illustrative of the fact that these whole body scans are not very sensitive. A TG level of 28, that's pretty worrisome. And if nobody's ever explained the antibody level to you, 20% or so of the population has antibody to thyroglobulin. Because the measurement of thyroglobulin is based on antibodies, if you have thyroglobulin antibodies, it interferes with how the thyroglobulin levels are measured. Now, there's ways to get around that, so you could talk to your doctor if you're one of those patients about getting around the antibody issue. But the doctors who were taking care of this patient saw that thyroglobulin of 28 with a negative ultrasound. They gave the patient 150 millicuries of I-131. The post-treatment whole body scan was negative. At the time of the treatment, the TSH was 48. The thyroglobulin level had gone to 42, and this is an antibody-negative patient. So now we have this information from surgery, the first iodine treatment, the second iodine treatment. Again, the stage is stage 2 because it was done at the original diagnosis. This is when this patient was referred to the University of Colorado Hospital. And the questions you have to ask is, she has disease, so where is it? And why did this patient keep having negative whole body scans? So maybe she didn't get the radioactive iodine that they gave her. Well, that's probably not likely. But there are other reasons why people might not have uptake on a whole body scan. We call this iodine contamination because maybe they had a CAT scan with iodine and interfered with the uptake. There's something called heterophile antibodies which interfere with how you measure thyroglobulin levels. They're not common. There's ways to test for that. That's not a likely explanation. Or the patient really doesn't have that much tumor. That's possible. It could be a biologically active tumor secreting a lot of thyroglobulin, but their overall tumor burden could be very low. or they have disease that just doesn't take up radioactive iodine. The latter two explanations are what I would say is the most common causes of this. Let's talk about the goals of repeat treatment. The patient has come back to you with persistent or recurrent disease, and what are our goals? Well, the first, and one that I think everybody in the audience has, and it's what I have, which is to rid this patient of disease. And how would we define that? Well, what we really would like to see is an undetectable thyroglobulin level, both on levothyroxine and either stimulated, and to have clean imaging. I think we also ought to think about, we don't want the patient to have a future recurrence. We want to avoid complications of treatment. Again, I've mentioned this a couple of times, but surgery has complications. Medical treatments have complications. We don't want the treatment to be worse than the disease. We want to prevent any type of impairments in your function or your quality of life. The disease itself could have problems that relate to functional or quality of life issues, and so can the treatments. And then if we elect not to do an intervention and to just observe this patient, we want to make sure that we prevent the progression, or if we detect progression, we detect it early enough and prevent impairment or quality of life problems. I think those are the goals that everybody has when we approach patients like this. Let's go back to the patient I'm using as an example. So when she came to the University of Colorado, we repeated her neck ultrasound, and lo and behold, there were 2 abnormal nodules in her thyroid bed. And this one that I've circled with red has microscopic echogenic foci in it. Those are high-risk lymph nodes, needle biopsies done. The patient has thyroid cancer in the central neck. That patient, we're going to recommend a central neck dissection. So if you came in after the last session, I defined in the previous section that the central neck is an anatomic border that starts at the hyoid bone. This is a pointer, isn't it? Whoops, I just turned off the projector. You know, I love surgeons who get up and talk about high-tech stuff and then they can't work a projector. Is there a pointer? Oh, just use the computer pointer? Yeah, you should technically trust me because I can't work a computer. The hyoid bone up here, the top of the sternum, which is the breastbone, and then the carotid artery, which you can't see well in this schematic, but on each side of the neck. The nodes are sitting right in front of the voice box. Those are what we call the Delphian nodes. Who's a Greek scholar? The Oracle of Delphi is how those were named. And then most of the nodes in the central neck sit in the groove between the trachea and the esophagus. And when the thyroid's in the neck, it kind of blocks the ultrasonographer's view of those lymph nodes. So one caveat that we warn patients about is that the ultrasound is not very good for the central neck if the thyroid is still there. Once the thyroid has been removed, the ultrasound in the central neck is quite good. So we're going to remove all of the nodes in that central neck. So I put a pause in here. If anybody's squeamish and doesn't want to look at a surgical picture, now's your time to close your eyes, and I don't see anybody closing their eyes. All right, so here's what a central neck looks like in surgery. The patient's head is towards your right, the feet are towards the left. This is the left neck you're looking from. The carotid artery is this structure that's starting right here and going upwards on that side. This patient has had a lateral neck dissection too, so you're seeing part of the lateral neck on the downside of this slide. You've seen the trachea is left in place, the larynx is left there. We leave the parathyroids or we auto-transplant them. And then this structure right here is the recurrent laryngeal nerve. So if you've never seen a picture of a recurrent laryngeal nerve to your vocal cord, that's it right there. Now, one of the controversies about central neck dissection is a central neck dissection done first operation less complicated than a reoperative central neck dissection, which would argue in favor of doing prophylactic neck dissections. Here's a whole line of series that have been published And the complication rate of permanent risk of hypoparathyroidism was 3.2%. Permanent nerve injury was 3.7%, but some of those nerves were sacrificed intentionally because they were involved with cancer. So the unintentional nerve injury risk was 1.5%. Now here's a collection of series of patients who've had reoperative central neck dissection. So they had a second procedure. And if you look at the bottom line again, temporary vocal cord paralysis was 6%, but permanent vocal cord paralysis was 2%. And then temporary hypocalcemia was close to 20%, permanent was 3.6%. That's not a lot different than the primary central neck dissection outcomes. Let's go back to our patient. I did a central neck dissection on this patient. She had 11 out of 15 lymph nodes that were positive. So next questions are, what should we do now? Should this patient get treated with more radioactive iodine? Brian Haugen saw her 2 months later and checked her TSH. It's appropriately suppressed on the levothyroxine. Her TG level is 1.8. It's still above 1. Before surgery, it had been 3.8. She still had negative antibodies. So there's our data. Oh, I add to that, he did a diagnostic whole body scan with 4 millicuries. At the time that was done, the TSH was 52, and the urinary iodine was checked to make sure that this patient had been following a low diet, and it was low. It was 78. There's the scan, and it's negative. When he stimulated her, the TSH went up, her thyroglobulin went up to 12, above 10, antibodies were negative, so now what should we do? Should we give the patient more radioactive iodine? Well, we elected to follow the patient for 6 months. Now the TSH is 0.05, the thyroglobulin is 3.2, so it's gone up a little bit. What do we do now? Anybody want to answer? Operate. It's easy for those non-surgeons to say that. Well, we did another neck ultrasound. And on the neck ultrasound, there's a lymph node in the lateral neck that was 11 by 5 by 3.5. And, you know, it wasn't completely normal, but it wasn't terribly suspicious either. But we elected to stick a needle in it. Brian also did a non-contrast CT scan of the neck, which was negative, and the cytology comes back negative. So what do we do now? No, actually, we did a thyroglobulin assay in the needle biopsy aspirate, and it came back at 42. So now the question is, what do we do? Well, before we get to what we do, let's pause and look at data on thyroglobulin assays in needle biopsy specimens. It turns out, let me just summarize, but it turns out that that's a very good test to detect cancer when the cytology is negative. There's a collection of studies that you see published over there. And what it's really good at is differentiating reactive lymph nodes that do and don't have cancer in them when the cytology comes back as not having cancer. So what our ultrasound doctors do is they collect it. If the cytology is negative, we send the TG wash. If the cytology is positive, you don't really need the TG in the wash, but we measure it anyway. Yes? A wash means that, you know, you've gotten the needle into the lymph node, they aspirate it, they stick the cells on the slide, the cytologist reads that, and then they take the needle and they wash it with saline, and they measure the thyroglobulin level in the saline. I've never actually done it. Is that right?
Yeah, that's right.
I send it to them. They do it.
We don't do it.
Right.
But that is how they do it. Yeah.
That's how they do it. Oh, and the other thing is that if you have antibodies, it turns out that the antibodies don't interfere with the thyroglobulin measurement in the aspirate. I'm glad you asked that, because I'm sure other people in the room were thinking the same question. They were like, what are you talking about?
Are the TG washes becoming more prevalent?
Yes. I won't tell you that it's, you know, widespread, but I think it is becoming much more prevalent because there's been a lot of publications that have found that it's very useful.
So if you have a thyroglobulin that's higher, you can't find the
No, the answer to that is really no, because which lymph node are you going to stick the needle in? You know, again, you have in your neck a lot of lymph nodes, so which one should we put the needle in? So I wouldn't advocate that, no. No other questions? All right, so then we did a lateral neck dissection on this patient. Lo and behold, she had 6 out of 38 positive lymph nodes. And 2 months later now, the TSH is 0.08, and lo and behold, the thyroglobulin level is now undetectable. Success, right? Now, lateral neck dissections. There have been innumerable number of incisions in order to do a lateral neck dissection. The most classic one is the one that's on the right. That's called a Mcphee incision. It's 2 horizontal incisions that are made in the neck. I personally prefer this incision because this incision allows you to do a thyroidectomy, a central and a lateral neck dissection through that incision. It's not as cosmetically pleasing as the incisions that are made horizontally because it crosses the skin lines. Everybody has skin lines. Some of you call those wrinkles, but they're really skin lines. There's actually an anatomist named Langer who did an entire mapping of the human body's skin lines, and he was a French anatomist. And in the neck, your skin lines are sort of horizontal and curve around the side of the neck. When you make an incision that crosses the skin lines, it's not as cosmetically pleasing as one that stays in the skin line. That's why the Mcphee incision was invented. I don't personally like doing neck dissections through the Mcphee because you have to deal with this bridge of skin between the 2 incisions, and your exposure isn't as good. But again, I'm not the one wearing the scar around. I've done many neck dissections through Mcphees, but I haven't done one actually for about 15 years through Mcphees because I don't like them. Does anybody have a Mcphee incision for a neck dissection? You do? There you go. Most thyroid surgeons don't like to use them. Oh, this one I don't know has a name. I call it the hockey stick. It's an L or a J depending upon what side of the neck but I call it the hockey stick. Now, the lateral neck, just like the central neck, is defined by the anatomy. And in thyroid cancer, the groups of lymph nodes that we most commonly see involved in thyroid cancer are levels 2, 3, and 4. And it's usually just level 2A, which is defined by the accessory nerve. A is in front of and B is behind. And then way over by the shoulder is level 5, which is not commonly involved with thyroid cancer. Having said that, remember I told you one of the rules of human biology is that there's always exceptions to the rule, and I see a patient in the audience who had level 5 disease. So that was an exception. Again, patient photo, if you don't want to see a surgical picture, this is a lateral neck dissection on that same patient that I showed you, and this is actually somebody that I did a level 5 dissection on. And so the carotid artery is the top tubular structure, the jugular vein is the middle structure. This white stripe right behind the jugular vein is the phrenic nerve. The phrenic nerve supplies the diaphragm. That's what you breathe with. You have 2 of them, so if one is paralyzed, you can still breathe. Most people at rest will not have any respiratory symptoms, but if you do heavy physical exercise or labor, the patient will experience this kind of breathless feeling. They feel like they can't catch a deep breath. And then this white stripe out here is the accessory nerve. That goes to the trapezius muscle. If you think of the linebackers in college football, they have those things on the back of their neck. That's the trapezius muscle. That allows you to raise your arms above your head. People with an accessory nerve injury have a weak shoulder. They can kind of raise their arms up to parallel to the floor, but they can't go up higher than that very effectively. So what they end up doing is turning their body sideways like that to get their neck up. And that's a problem if you have a kitchen with high shelves, let's say. That's a problem for patients. Now, my colleague, Dr. Abuha Cruz, did a little study of the experience with 140 neck dissections in 117 patients. Who asked about bilateral neck dissections? So there you go. Here's our experience with patients, and so you can conclude from that 23% 3 of the patients, we had to do a bilateral neck dissection out of 117 of them. The median follow-up was about 2 years. We had an 8% recurrence in the ipsilateral neck. Ipsilateral means the same side. That's a term that maybe some of you don't know. Here's the complication risk. We had a 6.8% intentional recurrent laryngeal nerve sacrifice, but only 1.7% of the time was there a nerve injury that wasn't intended. Then one patient each had a spinal accessory nerve injury, a hypoglossal nerve. The hypoglossal nerve is the motor nerve to your tongue. Taste is a different nerve. If you have a hypoglossal nerve injury, half of the tongue is paralyzed. If you stick your tongue out, it's going to deviate towards the side of the injury, and then that half of the tongue will shrink over time because your tongue is a muscle, and if a muscle is not innervated, it's going to atrophy. So that half of the tongue will shrink over time. 8% of the time there was a lymphocele, which means that patient had a persistent leakage of lymph in the drain, and then 0.8%, that's one patient out of 117, had a surgical site infection. And then looking at risk factors for recurrence, the number of positive lymph nodes was a risk, and the tumor size in the lymph node was a risk for recurrence. Now, is that an experience similar to what you'll find in the literature? And it is. So here's a collection of neck dissections and outcomes, and let's define it as biochemical remission. In other words, the thyroglobulin level is not detectable, and then no evidence of structural disease on the imaging. And in this collection of neck dissections, no biochemical remission occurred in between 21 and 66% of patients. And then no structural disease was between 51 and 100% of the patients. So that's what you would expect is the outcomes from a lateral neck dissection. Somebody asked a question? Oh, they didn't report it. I'm sorry. That was not reported. So that was something that wasn't in the paper. So now let's shift our focus a little bit to alternatives. Am I running out of time? Should we stop and have questions, or do people want? All right, well then let me zoom through a few things. So first is, should we just monitor thyroid bed nodules? And again, this is a study from Mike Tuttle's group, where they looked at patients who had thyroid bed nodules that were less than 11 millimeters. There were no suspicious features on the ultrasound in these nodules. There were no abnormal lymph nodes in the lateral neck, and the thyroglobulin level was not rising. Only 9% of the time did this patient have an increase in the size of that thyroid bed nodule. The average growth rate was 1.3 millimeters per year. And if there were no suspicious ultrasound features, there were no abnormal nodes in the lateral neck, and there was no rising thyroglobulin, there was a 93 to 97% ability to predict that this patient would not have progressive disease. So what this experience tells you is that if the doctor is carefully monitoring a thyroid bed nodule, it's a safe thing to do. What about abnormal lymph nodes in the lateral neck? Here's an experience with 166 patients. 99% of these lymph nodes were in the lateral neck, and the median follow-up was 3.5 years. Only 22 of these patients had FNA diagnosis that this was recurrent cancer. So a lot of these 166 patients might not have had recurrent cancer, but they had abnormal lymph nodes on the ultrasound. And then there were 13 patients that had distant metastasis. 12 of them that was present at the time that the study was started. So one question is, I bet everybody here has asked this question, is can it spread from the lymph nodes to the lung? This is one study that would say that that's not a likely occurrence, at least in this 3.5-year median follow-up. 20% of these lymph nodes had an increase in size during the follow-up of more than 3 millimeters. 9% it was greater than 5 millimeters. 14% of these patients, those lymph nodes were gone, the ones that were suspicious. And the median growth rate was 1.5 millimeters per year, not very fast. There were no local complications from these lymph nodes. And the things that predicted progression of disease is that if they had a PET scan and it took up the FDG, if the lymph node was small at the time the study was entered, I mean, that's like saying, that Douglas County is the fastest growing county. Well, there's not a lot of people that live in Douglas County, so you add a few people and it has a fast growth rate, right? If the TG level was increasing, and if there was increased vascularity in the lymph node, those things all predicted that the lymph node would progress. Now, what about alternative treatments? Some of you may have heard about ethanol injections. This can be done in a limited number of lymph nodes. You can't have a lot of lymph node disease and get ethanol injection as the treatment. We generally use it in people who've had a compartment-oriented neck dissection. If somebody had an inadequate neck dissection, we generally are going to go back and do a neck dissection first. But if you've had a good neck dissection, you have recurrence in that area, ethanol might be an alternative. Sometimes this requires repeated treatment. It's often not just a single thing. And then the ultrasonographer can monitor the injection in real time so that they can see exactly how much ethanol is being infused into the lymph node. And what I've shown you here is just that these ultrasonographers used a map of where the nodes were, and then there's just a couple of ultrasound views of an injection. Here's 4 different studies in reporting their experience. The yellow, the 63 patient experience, is the largest experience that's published. And what you see in the data is that there's a fairly high success rate in controlling this disease. In the largest study, it was 84%. In the study from Ian Hay, which is the third one down, that's at the Mayo Clinic, 46% of the time the node disappeared, and in 82% of the time the thyroglobulin level actually went down. There's another treatment called radiofrequency ablation, which is a little bit like microwaving the lymph node with a probe that's stuck into the lymph node. Very similar treatment considerations as ethanol injection. And here's a I took this out of this publication that was in September of 2014. That's how current this is. The image B is the actual probe stuck into a tumor, and then image D is a follow-up ultrasound which shows that tumor is gone. So 82% of the time the RFA led to a disappearance in that recurrent node. Do you have a question?
That looks like a central part node.
It is. You're right.
And that was successful?
That was successful. You see in image D that the tumor is gone. Is time up? That's all right, because I think I only had like 2 more slides. We got to move on to the next speaker. You guys have been a great audience. You've asked a lot of great questions. Thanks for your participation.